Good afternoon, everyone. I'm audible and visible to all of you. Please update me in the comment section. Yes. So can we start? Okay, guys. So let's begin with the part 1 of pediatrics. Okay. We'll see how much we'll be able to cover. Okay. So let's begin with the first question. We'll be having the same question, followed by that we'll go with the discussion. Okay. So starting with the first question. A 3-day-old term newborn present with a yellowish discoloration of the skin and the sclera. The baby is otherwise active, feeding well, and has a normal stool and urine output. The serum bilirubin levels are 10 mg per deciliter with predominantly unconjugated bilirubin. What is the most likely diagnosis? What is the most likely diagnosis? Okay, so the question from the neonatal jaundice. Okay, and you might have already studied about physiological jaundice, about a pathological jaundice, about a breast milk jaundice or breastfeeding jaundice. Okay, so the main two one are the pathological jaundice and the physiological jaundice. Okay, so what will be be the answer of the given question? Yes, so let's discuss about the jaundice first. Okay, chale. Now how do we define this neonatal jaundice? So when the bilirubin levels, it's defined when the bilirubin level is more than 5 mg per deciliter. Okay, so it's defined as bilirubin levels more than 5 mg per deciliter, not the normal one. It is a neonatal jaundice. Please do remember, guys, that we call as a neonatal jaundice. Okay, followed by that we have two types. We have physiological jaundice and a neonatal jaundice. Okay, now if we talk about the differences between the physiological jaundice and the pathological jaundice, the onset of the physiological jaundice, it appears after 24 hours of life. So it appears after 24 hours of life. Okay, usually on the second and the third day. Okay, if we talk about a pathological jaundice, it appears within 24 hours. It appears within 24 hours of life. So the question, whenever you see, please do check the onset. It will be easy for you to crack the answer. Okay, so if it appears within 24 hours of life, the jaundice is going to be the pathological jaundice, and if after 24 hours of the life, it's going to be the physiological jaundice. If we talk about the peak level of the physiological jaundice, it peaks on day 5. It peaks on day 3 to 5. Okay, and pathological jaundice, it may peak at any time. It may peak at any time. It may peak at any time. Followed by that, if we talk about the duration, the physiological jaundice, it resolves by 1 to 2 weeks. So it resolves by 1 to 2 weeks. Okay, but if it is term, 1 to 2 weeks. If preterm, up to 3 weeks. Okay, 1 to 2 weeks for the term, and preterm, so that's going to be 2 to 3 weeks. Preterm, that is going to be 2 to 3 weeks. If we talk about the duration of the, okay, if we talk about the duration of a pathological jaundice, it persists beyond the normal time. it persists beyond the normal time. Okay, followed by that, the bilirubin levels, typically in case of a physiological jaundice the levels are less than 15, but in case of a pathological jaundice they are more than 15. Okay, within first 24 hours it is more than 5. So they are less than or equal to 15 mg per deciliter, and here they are more than 15 mg per deciliter. Okay, and in the pathological jaundice the bilirubin levels they increase by more than 5 mg per deciliter every day. Clear? More than 5 mg per deciliter every day. If we talk about the cause of a physiological jaundice, the cause is going to be immature liver enzymes. I'm going with a very short and concise way. There are multiple causes, and if we talk about a pathological jaundice, it can be hemolysis or infection. Hemolysis or infection. Okay, talking about the type of a hyperbilirubinemia, remember physiological jaundice, it's always going to be conjugated bilirubin. It's always going to be conjugated bilirubin, but in case of an pathological jaundice it can be conjugated or unconjugated. So it can be conjugated or unconjugated. If we talk about the risk factors in the physiological jaundice is going to be preterm or delayed feeding. Okay, and here it is usually hemolysis in view of RH incompatibility. We have discussed in the obstetrics and gynecology about the RH incompatibility when there is an antibody against the red cell which results in the hemolysis. Further, there will be a antigen antibody reaction. Okay, hemolysis is occurring, and followed by that there is a third space collection fluid which results in a complication called as hydrops fetalis. Okay, and one more complication we have studied in which erythropoiesis is compensated by the hemolysis is compensated by the bone marrow hyperplasia. The condition is called as erythroblastosis fetalis. The condition is called as erythroblastosis fetalis. Okay, the complications are rare. It's usually the benign, but in case of a pathological jaundice it can lead to the kernicterus. Okay, then the management. So in case of a physiological jaundice we should go for the frequent feeding, and here treat the underlying cause and go for the phototherapy. Treat the underlying cause and we should go for the phototherapy. So it's a difference between a physiological jaundice and a pathological jaundice. Okay, one more. Now the question is that the bilirubin level is 10 mg per deciliter. So usually I just mentioned that if the levels are less than 15, the answer is going to be yes, the answer is going to be physiological jaundice. Clear? Yes. Now one more option is there, breast milk jaundice. So what exactly is the breast milk jaundice? There are the substances inside the milk which interferes and resulting into the jaundice. So what are the substances? Just remember that substances like fatty acids and pregnanidiol, free fatty acids and pregnandiol. they interfere with the breast milk and eventually lead to the jaundice okay. So they will interfere with the conjugation of the bilirubin and eventually lead to the jaundice. That is called as breast milk jaundice. I will write here, interferes with conjugated bilirubin. They interfere with conjugated bilirubin. Is that clear? So that is a breast milk jaundice. Okay, what exactly you have to treat? How to treat this breast milk jaundice? Sir, continue the feed, but if it goes more than 20 mg per deciliter, then you have to treat accordingly. Okay, then withhold the breastfeeding. Okay, continue the breastfeeding in the breast milk jaundice, but if it goes more than 20, withhold the breastfeeding. Okay, now one more question they can ask, that conjugated bilirubin is increased in, so you will remember CDR. C is conjugated bilirubin. Okay, so remember, D is Dubin-Johnson and R is Rotor. R as Rotor syndrome. Clear? Okay, unconjugated, it's CJN1, CJN2 and Gilbert syndrome. Unconjugated, CJN1, CJN2 and the Gilbert syndrome. Clear? Chalo, आगे बढ़ते हैं. Now a neonatal hypoglycemia, the question they can ask from the neonatal hypoglycemia, what is the definition? When the blood glucose level, how do we define neonatal hypoglycemia? So the blood glucose is less than 40 mg per deciliter, or the plasma glucose is less than 45 mg per deciliter. This is called as neonatal hypoglycemia. WHO definition says, as per the WHO, it is less than 45 mg per deciliter blood glucose. Less than 45 mg per deciliter blood glucose. Okay. Now talking about the clinical features of a patient, of a neonate having a hypoglycemia, baby will have most common clinical feature is going to be tremors. Baby को क्या होगा? Tremors. Followed by that, there will be apnea. There can be seizures. Okay, there can be apnea. There can be seizures. What can be the other clinical features? Write down in the comment section, guys. What can be the other clinical features? Yes, there can be a poor feeding. There will be a poor feeding and the baby will have increased sweating. The baby will have increased sweating. These are the clinical features. Now the treatment of the neonatal hypoglycemia will be depend on whether the patient is symptomatic or asymptomatic. Okay, so if it is symptomatic, very short manner, sir, if it is symptomatic, the treatment is going to be IV 10% dextrose. IV 10% dextrose. Okay, if a patient is asymptomatic, so we need to continue the breastfeed and monitor glucose levels Okay, but if the glucose level is more than 20 to 40, if the glucose level is more than 20, okay, then continue the breastfeed. If less than 20, you need to start the glucose infusion. You need to start the glucose infusion. You need to start the glucose infusion. That is about the neonatal hypoglycemia. So remember, the blood glucose levels less than 40 mg per deciliter. Okay, as per the WHO definition, it is less than 45 mg per deciliter. Most common clinical feature is going to be tremors. Okay, what are the other features? Patient is going to have an apnea, seizures, poor feeding, and increased sweating. Okay, treatment, we have to give IV 10% dextrose. If asymptomatic, if a patient is asymptomatic, then continue the breastfeed if the glucose level is more than 20 to 40 mg per deciliter. But again, if it is less than 20, start the glucose infusion. Start the glucose infusion. Clear? Clear, guys? Yes? Everyone in the comment section? Chale. Now next is going to be the treatment diagnosis for the pneumonia as per the latest guidelines. Okay, as per the latest guidelines, they can ask the question from this. Okay, now any child less than 5 years with fever and the respiratory symptoms comes. Okay, so first of all, define the fast breathing. Okay, define the fast breathing. So what is fast breathing respiratory rate? In less than 2 months, it is 60 per minute or more. If we talk about 2 to 12 months, it's 50 per minute or more than that. Okay, and 1 to 5 years, it's 40 per minute or more. It's 40 per minute or more. Okay, so first of all, you need to see what exactly is the respiratory rate. If the age of the baby is less than 2 months, the respiratory rate 60 per minute or more. 2 to 12, 50 per minute. 1 to 5, then 40 per minute. Then the next step is going to be see the chest indrawing or the chest retractions present or not. Okay, see the chest retractions are there or not, and then look for the danger signs. Then look for the danger signs. So what exactly are the danger signs? Write it down. So danger sign like convulsions. Danger sign like convulsions. There is protein energy malnutrition. There is severe PEM, protein energy malnutrition. Sir, inability to feed or drink. Inability to feed or drink. Okay, or abnormal sleep. Okay, or a baby is lethargic, or the baby is lethargic. These are all the danger signs. These are all the danger signs. Okay, followed by that, then you can categorize whether the patient is having a severe pneumonia or a pneumonia or no pneumonia. Okay, then if there is any dangerous sign, or the chest indrawing or there is a stridor present, it will be categorized as a severe pneumonia or a very severe disease. So remember, if in a question it will be mentioned that a baby, a neonate, a baby is having a chest indrawing or the stridor, or the child is having a stridor or any danger sign, whether it's convulsions, it's lethargic, it's severe protein energy malnutrition, or inability to feed or drink. Okay, these danger signs are present, you categorize it as a severe pneumonia. So what will be the treatment, sir, for the severe pneumonia? You have to give first dose of IV antibiotics. You need to give first dose of IV antibiotics. What are the antibiotics you will give as per the latest guidelines? Sir, ampicillin plus gentamicin. And then refer to the high center. Refer to higher center and make sure the child will go on the oxygen. Refer on auto. Okay, that will be the treatment for the severe pneumonia or a very severe disease. Okay, then if a baby is having the fast breathing, if a child is having fast breathing or sir chest indrawing. If it's having a fast breathing or the chest indrawing, you categorize it as a pneumonia. You categorize it as a pneumonia. So what will be the treatment? Sir, you'll give oral amoxicillin for 5 days. And review and follow up in OPD. You'll give oral amoxicillin, tablet amoxicillin for 5 days and follow up in OPD. Okay. And if there is no signs, of pneumonia or very severe disease or no danger signs present, okay, there is no pneumonia, okay, cough or cold, so what exactly you need to do? So no antibiotics, only supportive treatment. No antibiotics, only supportive treatment. So first of all, guys, check whether the danger signs are present. Followed by that, do check whether the type of the pneumonia is going to be severe or pneumonia or the no pneumonia, depending upon the danger signs. If danger signs are there, treatment is going to be the IV antibiotics, ampicillin and gentamicin. If fast breathing or chest indrawing is present, categorize it as a pneumonia. So you'll be giving oral amoxicillin for 5 days and follow up in the OPD. And if there are no danger signs present, that is going to be no pneumonia, cough or cold, no antibiotics to be given. Okay, just the supportive treatment. Clear? Yes, write down in the comment section, everyone. It's clear? Chalo, let's move to the next part. A baby is born at 27 weeks gestation, weighing 900 grams. 27 weeks gestation, 900 grams, and is on ventilator support. Okay, extremely low birth weight. What is the recommended initial mode of feeding? Tell me, guys, what is the recommended initial mode of feeding? So let's discuss about the feeding of preterm neonate. Okay, gestational age and the mode. Gestational age and mode of feeding. Okay, first, if it is less than 28 weeks, if it's less than 28 weeks, IV fluids only. IV fluids plus minus total parenteral nutrition, TPN. IV fluids plus minus TPN. Okay, if 28 to 31 weeks, we'll use orogastric tube feeding. Okay, if it is 32 to 34 weeks, if it's 32 to 34 weeks, it is Katori spoon or Paladai feeding. And more than 34 weeks, breastfeeding. More than 34 weeks, breastfeeding. So here the question was asked, it's less than 28 weeks. So how do you feed? Initial mode of feeding, that's going to be IV fluids with or without total parenteral nutrition. It's IV fluids with or without total parenteral nutrition. Clear? Chalo. Next question. What is the drug of choice for treating a 4-year-old male child who present with generalized tonic-clonic seizures associated with fever for past 4 months, and MRI reveals the multiple ring enhancing lesion with perifocal edema? So Is the diagnosis of a condition, guys? Patient is coming with a seizures, with a neuroimaging reveals that there are ring enhancing lesions. So what is the diagnosis? Write down in the comment section. What is the diagnosis? Ring enhancing lesions. Very good. So the diagnosis is going to be Neurocysticercosis. Okay, and we have which type of appearance? This multiple ring enhancing lesions, they give a starry sky appearance. So they give a starry sky appearance. Okay, usually due to the tinea solium and tinea saginata, POC की वजह से होता है. And the most common feature is going to be seizures. Okay, most common feature is going to be seizures. And what is a drug of choice? What is a drug of choice for that? Drug of choice is going to be albendazole. Drug of choice is going to be albendazole. Along with the albendazole, sir, we give also steroids. We give also steroids which will decrease the inflammation. Okay, we give prednisolone or a dexamethasone which will decrease the inflammation. Okay, mebendazole, ivermectin and DC. DC usually is a main drug of choice for the filariasis, along with the ivermectin. These AID are the 3 drugs that we use in filariasis. We have discussed that as well. So remember, for the neurocysticercosis, okay, the drug of choice is going to be the albendazole plus steroids. So steroids क्या करते हैं? Steroids will decrease the inflammation. Steroids will decrease the inflammation. चले. Next, a girl is born at term after an uneventful pregnancy and delivery. On examination, she is hypotonic, has a protruded tongue, low set ears, and upward slant to the eyes with epicanthal folds and a single palmar crease. On cardiac evaluation, what is the most common lesion expected in this syndrome? What is the most common lesion expected in this syndrome? So what is your diagnosis? So the diagnosis is going to be Down syndrome. All the findings, as per the findings, what is the diagnosis? So the diagnosis is going to be the Down syndrome. Okay, and the most common cardiac defect associated with Down syndrome is going to be endocardial cushion defect. That is going to be endocardial cushion defect. So let's discuss about the Down syndrome. You all know Down syndrome. It's going to be trisomy 21. So trisomy 21. Okay, what are the features of a patient having a Down syndrome? First one, there is a growth failure, mental retardation. Okay, there are slanting eyes, epicanthic fold with short nose, congenital heart disease, and the most common one, as I've already said, the most common one is going to be endocardial cushion defect. Okay, endocardial cushion defect. Okay, and then patient can have umbilical hernia, diminished muscle tone, short hand and broad hands. Okay, there is a single palmar crease. Okay, along with that other features that the Down syndrome baby is having, these are more prone to some conditions like duodenal atresia. They are more prone to duodenal atresia or Hirschsprung disease. Duodenal atresia, Hirschsprung disease. Okay, and if we talk about Alzheimer's disease, ApoE4 protein is on chromosome 21, and Down syndrome is trisomy 21. So the Down syndrome patients can have Alzheimer's disease as well. They can have Alzheimer's disease as well. Clear? Yes, everyone. They can have an Alzheimer's disease as well. Okay, now the question that they ask from the Down syndrome also is going to be the triple test and the quadruple test. Okay, what will be the levels of parameters of triple test in view of a Down syndrome and as well as a quadruple test? If we talk about the triple test, what are the parameters in the triple test? So we're going to check beta HCG. Okay, we have estriol and alpha fetoprotein Okay, beta HCG is going to be high in case of a Down syndrome, estradiol will be less and AFP will be also decreased. Okay, if we talk about a quadruple test, it's going to be triple test plus inhibin A. So inhibin A, remember, it is going to be decreased. So inhibin A is decreased. Inhibin A is decreased in Down syndrome. Inhibin A is decreased in Down syndrome. So 2 questions from this particular thing. Either they ask the components of a quadruple test and the triple test. We have already discussed in obstetrics and gynecology. But here, do remember, in quadruple test of a Down syndrome, beta HCG is increased, rest all are decreased. Rest all are decreased. Clear? Chale, next question. A 6-year-old boy present with an abdominal pain and non-blanching palpable purpura over the lower limbs and the bloody stools. There is a mild joint swelling. Urine shows the microscopic hematuria and the platelet count is normal. Okay. So what exactly is your diagnosis? So see, these are the purpura present. A baby is coming with a purpura over the lower limbs, and baby is having a hematuria as well. There is joint pain or joint swelling as well, but remember the platelet count is normal, so that means it is a non-thrombocytic purpura. क्या है ये sir? It's a non-thrombocytic purpura. So which type of vasculitis? It's going to be Henoch-Schonlein purpura, HSP. Okay, it's going to be HSP. Now let's discuss about the HSP. First of all, sir, this HSP, it's going to be most common. It's going to be most common vasculitis in pediatric age group. So it's a most common vasculitis in pediatric age group. Okay, which hypersensitivity reaction? Type 3 hypersensitivity reaction. It's type 3 hypersensitivity. Chalo. Okay, now if we talk about the clinical features, remember, if we talk about the clinical features, sir, out of the following at least one should be present. Okay, what are the features? We have arthritis or arthralgia, arthritis or arthralgia. We have abdominal pain, okay, there should be renal involvement, hematuria, okay, and any biopsy shows IgA presence, shows IgA deposition. So do remember guys, any palpable purpura, okay, palpable purpura, along with that one should be present, either arthralgia, abdominal pain, hematuria, and biopsy should show the IgA deposition. Biopsy should show the IgA deposition. Your answer is going to be the HSP. Your answer is going to be the HSP. Okay, one important hint that they can mention in the question, that platelet is normal. So platelet count is normal. That's why I have mentioned that this is a non-thrombocytic purpura. This is going to be the non-thrombocytic purpura. And what exactly is the reason for this purpura? The purpura, it is due to vasculitis. So purpura due to vasculitis. Purpura due to vasculitis. Clear? Purpura due to vasculitis. Is that clear? Is that clear to everyone? Please update in the comment section, guys. Chale. Let's move to the next question. A child present with a bilateral conjunctivitis peeling of skin and fever since 5 days. What is the likely diagnosis? Very easy one. Bilateral conjunctivitis, skin, fever for 5 days. It's going to be the Kawasaki disease. It's going to be the Kawasaki disease. So let's discuss what exactly is a Kawasaki disease. Okay, it's Kawasaki disease. It's also known as mucocutaneous lymph node syndrome. And syndrome. Okay, and it usually affect the age group less than 4 years. It usually affect the age group less than 4 years. Okay, now what are the clinical features? So the clinical features are mnemonic, cream or crash. C is going to be conjunctivitis. C, it's going to be conjunctivitis, and remember there is going to be bilateral non-purulent conjunctivitis. It is bilateral non-purulent conjunctivitis. R is rash. R is rash. A is going to be adenopathy. A is adenopathy. Usually which adenopathy? Cervical adenopathy. Okay. S, it's going to be strawberry tongue. Strawberry tongue, also seen in the scarlet fever. Okay, and H is hand and feet swelling. Edema. Is that clear? So that is going to be the features of Kawasaki disease. And do remember that along with this, patient is going to have a fever more than 5 days. Baby will have a fever of more than 5 days. So since 5 days fever is there is bilateral conjunctivitis. The question they can ask is which of the following is not a feature, not a feature of an Kawasaki disease. So they will mention a non-purulent, they will mention a purulent conjunctivitis. So it's exactly a non-purulent conjunctivitis that is seen in the Kawasaki disease. Clear? Now due to the involvement of the coronary arteries, the patient can have a myocardial infarction. Myocardial infarction. Okay, and what is the treatment? So treatment is IV immunoglobulin. Treatment is IV immunoglobulin and aspirin. IV immunoglobulin and aspirin. Okay, and if IVIG is not working, then we can go for the steroids, and it's the only condition in children where we are giving the aspirin. Okay, otherwise aspirin causes Ray's syndrome. Aspirin causes Ray's syndrome. Okay, now the image that they can ask from the Kawasaki disease. The first one, image A, it's a mycopapular rash. It's a mycopapular rash seen in the Kawasaki disease. Image B, this is conjunctivitis. But do remember, bache, that this is going to be a non-purulent conjunctivitis. It's going to be a non-purulent conjunctivitis. Image C is a strawberry tongue. Okay, then followed by that we have feet swelling. Okay, plantar erythemas and palmar erythema. Okay, feet and hand swelling, edema, plantar and palmar. Okay, then we are A is going to be adenopathy. We have cervical adenopathy. Cervical adenopathy. Okay, here you can see guys, coronary artery, and here the most common complication, that is going to be coronary artery aneurysm. Okay, if the question is what is the most common complication in the Kawasaki disease, your answer is going to be coronary artery aneurysm. Okay, coronary artery aneurysm, and followed by that, the last one, guys, we can have a peripheral artery aneurysm. We can have a peripheral artery aneurysm. Okay, so these are all the features of a Kawasaki disease. Remember, guys, the treatment is going to be IV immunoglobulin. If that is not working, then we can give the steroids. Along with that, aspirin. Okay, so what are the features? We are having conjunctivitis, rash, adenopathy, strawberry tongue, and the edema. So do remember HSP and the Kawasaki disease, vasculitis. Next question, which of the following is not typically associated with congenital hypertrophic pyloric stenosis, CHPS? So the pediatric surgery question, guys, which of the following is not typically associated with congenital hypertrophic pyloric stenosis? Yes, write down in the comment section answer. What will be the answer, bache? Chale, let's discuss about the CHPS. Okay, so what is CHPS? Sir, it's a hypertrophy of the pylorus it's a hypertrophy of the pylorus which is leading to the gastric outlet obstruction. Leading to the gastric outlet obstruction. Okay, and it's most commonly seen in the male babies compared to female around the 6 to 8 weeks of life. Around 6 to 8 weeks of life. So what is CHPS? It's a hypertrophy of the pylorus which is leading to the gastric outlet obstruction, usually seen in the males compared to females around 6 to 8 weeks of life. Okay, now if we talk about the clinical features of a patient having a CHPS, a baby, first of all, baby will complain of vomiting, but it's going to be projectile in nature and non-bilious. Projectile and non-bilious vomiting. Okay, there is a palpable lump which will be felt from the left side. There is a palpable lump felt from left side. That's why in questions they will mention olive mass. Okay, and baby, due to the continuous vomiting, there will be dehydration and weight loss. There will be dehydration and weight loss, and there will be a visible gastric peristalsis. Be visible gastric peristalsis. Okay, now the question was asked, which of the following is not typically associated with congenital hypertrophic pyloric stenosis? So visible gastric peristalsis, yes, it is there. Sir, olive-shaped mass in the right upper quadrant, yes, it's there. Sir, it occurs between 2 to 6 weeks of life, yes, it's there. Sir, bilious vomiting, no, it's going to be the non-bilious vomiting. So about the bilious vomiting, if present, think of a duodenal atresia. Think of a duodenal atresia. Think of a duodenal atresia. Okay, followed by that, the more repeated question that they have asked about electrolyte imbalances. What is an electrolyte imbalance seen in a patient having a CHPS? It's hypokalemia. Sir, it's hypokalemia. It's hypochloremia. Hypokalemia, hypochloremia, metabolic alkalosis. Metabolic alkalosis. Okay, hypokalemic, metabolic alkalosis. Okay, the risk factor that can lead to the CHPS is a maternal intake of a drug. What is a drug which can lead to the CHPS? Maternal intake of a drug belong to the class macrolides. It is erythromycin. So maternal intake of erythromycin. Maternal intake of erythromycin. Maternal intake of a drug erythromycin, because erythromycin can lead to the CHPS. Okay, for the diagnosis we are going for USG abdomen, and USG is the investigation of choice as well. Okay, and the sign that is seen in CHPS, it's like a donut. So this sign is called as donut sign. This sign is called as donut sign. Okay, and what will be the treatment? So the treatment is going to be the surgical treatment. So surgical treatment called as Ramsted's operation. Ramsted's operation, and we should give IV fluids. Okay, normal saline with added potassium, because patient is having hypokalemia as well. Patient is having hypokalemia as well. Clear? So this is all about the CHPS. Okay, one more thing guys, they can mention what is the thickness of the pyloric muscle, because there is a hypertrophy. It is more than or equal to 4 mm. Okay, and the length of a canal is 14 mm, more than 14 mm. Okay, so that's all about CHPS. So CHPS, it's a hypertrophy of the pylorus which is leading to the gastric outlet obstruction. The clinical features of a non-bilious vomiting around 6 to 8 weeks of life, and the palpable lump which is a olive mass, and there is a visible gastric peristalsis. Okay, the electrolyte imbalance, the question that they've asked, the metabolic alkalosis with hypokalemia and hypochloremia. Okay, the risk factor is a drug which can lead, is called the drug erythromycin, and the investigation of choice is USG abdomen with treatment of Ramsted's pylorectomy or Ramsted's operation, and give IV fluids, normal saline with added potassium. The sign is donut sign. Okay, let's move to the next question guys. A newborn has the following findings at 1 minute after the birth: heart rate of 120 beats per minute, weak cry, some flexion of extremities, acrocyanosis, and grimace when stimulated. What is the Apgar score? Now tell me in the comment section guys, what is the Apgar score for the patient? Okay, the heart rate is 120 beats per minute. Okay, along with that, the weak cry, there is some flexion of the extremities, there is acrocyanosis and grimace when stimulated. So tell me what exactly is the Apgar score. Okay, now you already know guys, this Apgar score, it's a prognostic score. Okay, number second thing is, it is done at 1 minute and 5 minutes of done at 1 minute and 5 minutes, and this score indicates whether the patient needs a resuscitation or not. Okay, and if the score is less than 3, okay, less than 3, sir, needs resuscitation. So needs resuscitation. Okay, so let's understand what exactly is the Apgar score first, and then we go. Okay, now in Apgar score, if we talk about the first appearance, if we talk about the appearance, the score of 0 if it is bluish gray or pale skin. Okay, if it is bluish gray or the pale skin, the score is 0. If there is a pink body with a blue hand or feet, pink body with a blue hand or feet, this is what you call acrocyanosis. Acrocyanosis, the score of 1. Okay, entire body is pink, you give a score of 2. Entire body is pink, we give a score of 2. Okay, then if we talk about the pulse, okay, if no pulse, the score is going to be 0. No pulse, score is 0. If it is 100 beats per minute, if it's 100 beats per minute, score of 1. If it's at least 100 beats per minute or more, the score of 2. The score of 2. Followed by that, if we talk about the reflexes, if there is no response, it's 0. If there is some reflexes, grimace, it's 1. If there is cry, away or sneeze, it's going to be score of 2. It's going to be score of 2. If we talk about the activity and the muscle tone, okay, weak movements, it's score 0. Some movements of the arms and legs, it's going to be score of 1. And active movement, it's going to be score of 2. Then talking about a respiration, do remember bache, it is not the respiratory rate, it is a respiratory effort in Apgar score. First question they can ask, which of the following is not a parameter of an Apgar score? It is a respiratory effort. Remember, it's respiratory effort, not the respiratory rate. It's respiratory effort, not the respiratory rate. Okay, chale. Now sir, if not breathing, the score of 0. If irregular breathing or a weak cry, it's score of 1. And if there is a normal breathing with a strong cry, okay, that's going to be score of 2. So let's calculate whatever given in the question, guys. First of all, sir, the heart rate. First of all, heart rate is given. So right, sir, heart rate is 120 beats per minute. Heart rate is 120 beats per minute. So 120 beats per minute, that is going to be more than 100. That is going to be score of 2. So 2 points. Okay, next is going to be the weak cry. If the baby is having a weak cry, that is a score of 1. Weak cry, that will give you the 1 point. Okay, followed by that, there is some flexion of the extremities. Okay, there is some flexion of the extremities, again that is going to be 1 point. Some flexion of the extremities, some movement, that is going to be 1 point. Okay, followed by that, there is pink acrocyanosis, that is pink body with blue hand or feet. Again, acrocyanosis will have a 1 point. Followed by that, grimace, 1. So the total of 6. So the Apgar is 6. So the Apgar score of a given scenario is 6. So calculate. First see whether the heart rate is no pulse, 0. It's under 100, it's 1. And if it is above 100, it's going to be 2. Then the appearance, if bluish gray or pale skin, that's going to be 0. Pink body or the acrocyanosis is going to be 1. If the entire body is pink, that's going to be 2. Okay, followed by that, the activity muscle tone. If there is a weak moment, 0, some flexion, some moment is 1, and active moment is going to be 2. Remember, it's a respiratory effort, not the respiratory rate. It's a respiratory effort, not the respiratory rate. Clear? Now this image, it's going to be the Shakir's tape. So this Shakir's tape is used to measure the mid upper arm circumference. Mid upper arm circumference. Mid upper arm circumference. Okay, and this Shakir's tape, it gives me about the growth and the nutritional status of a child. Gives about the growth and nutritional state. Okay, and it's usually used by the field workers, okay, to assess the nutritional status. It has 3 colored zones. It has a red zone, it has yellow zone, and the blue zone, and the green zone. Okay, we have red zone, yellow zone, and we have the green zone. Okay, so the red zone is when it's less than 11.5 centimeter. Okay, yellow zone, it is 11.5 centimeter to 12.5 centimeter, and green zone, it's going to be more than 12.5 centimeter. It's going to be more than 12.5 centimeter. Red zone, it's malnourished child or undernutrition. It is malnourished or under nutrition. Yellow zone, it is borderline nutritional status, and green zone, it is a normal nutrition. It is a normal nutrition. Is that clear? So that is mid upper arm circumference with the Shakir's tape. Malnourished, borderline, and the normal nutrition. This is used to measure the skin fold thickness, called as Harpenden calipers. Harpenden calipers. Okay, it's used to measure the skin fold thickness. Skin fold thickness. Okay, do remember what are the exactly sites that we usually measure the skin fold thickness? We have biceps area, triceps area, and suprascapular area. So how do you remember? BTS, biceps, triceps, and suprascapular or subscapular. Okay, chalo. That's all about Shakir's tape. That is all about the Shakir's tape and the Harpenden calipers. Okay. A mother reported to the OPD with a complaint that her child smells funny. On examination, you notice that the child has a global developmental delay and smells mousy. What is your probable diagnosis? What is your probable diagnosis? So let's talk about the different conditions: phenylketonuria, alkaptonuria. Okay, and if the child is smelling the mousy odor, if there is a mousy odor, that's going to be, yes, write down in the comment section, that's going to be phenylketonuria. That's going to be phenylketonuria. Okay, now let's understand what exactly is a phenylketonuria. Sir, it is due to the deficiency of So phenylketonuria is due to the deficiency of an enzyme phenylalanine hydroxylase. It's due to the deficiency of an enzyme phenylalanine hydroxylase. Okay, the order is going to be mousy or musty order. There is mousy or musty order. Okay, and if we talk about the enzyme phenylalanine hydroxylase, it helps in the conversion of phenylalanine. It helps in the conversion of phenylalanine to tyrosine. Okay, and the enzyme is phenylalanine hydroxylase. Now if the conversion of phenylalanine to tyrosine is not done, what will happen to the levels of phenylalanine? They will be increased and tyrosine will be decreased. When the tyrosine is decreased, the substances from the tyrosine, what are the things coming from the tyrosine? We have melanin, okay, we have catecholamines, we have T3, T4. So it will result in what? It will result in decreased melanin. Okay, it will result in decreased melanin, and the baby will have, or the patient will have, hypopigmentation. Can have hypopigmentation. Is that clear? Can have hypopigmentation. And if there is increased levels of phenylalanine in the body, they are toxic to CNS. They are toxic to CNS. So the baby, the patient who is coming, okay, the child who is coming can have a neurological manifestation. Child can have the neurological manifestation. Okay, so remember what will be the treatments are? Low phenylalanine diet and tyrosine supplementations. What will be the treatment for this condition? So we need to give low phenylalanine diet and tyrosine supplementation. And tyrosine supplementation. So this is about a phenylketonuria. So what are the features of a patient having a phenylketonuria? What are the features of a patient having the phenylketonuria? Yes, so the features of patient having a phenylketonuria will be CNS manifestation or the hypopigmentation Clear? Chale, next one is alkaptonuria. You already know about this alkaptonuria as well. So alkaptonuria, it's due to the deficiency of homogentisate oxidase. Homogentisate oxidase. Okay, there is an accumulation of homogentic acid, which will further lead to the blue black pigmentation of sclera. Blue black pigmentation of sclera and cartilage. Okay, and this blue black pigmentation is called as ochronosis. Clear? Chale. So there is an accumulation of a homogentisic acid which will lead to the blue black pigmentation of a cartilage and sclera called as ochronosis. Okay, called as ochronosis. And On standing, there will be the darkening of urine. So right, darkening of urine on standing is a feature of darkening of the urine on standing. So it's a feature of alkaptonuria. It's a feature of alkaptonuria. It's a feature of alkaptonuria. Is that clear? Yes. So remember, the smell mousy odor with a global development delay, it's going to be the phenylketonuria. Okay, now other things, guys, if we talk about the tyrosinemia, okay, if you talk about the tyrosinemia, the smell is of the body odor is boiled cabbage odor. Boiled cabbage odor. Okay, if you talk about Henoch-Schonlein, it's sweet or sulfur odor. Sweet or sulfur odor. Okay, if we talk about hypermethionemia, it's a fishy odor. It's going to be the fishy odor. Okay, further we have one more, guys, burnt sugar odor. Can you tell me in the comment section? Burnt sugar odor. So burnt sugar odor is classically seen in maple syrup urine disease. Maple syrup urine disease. Okay, and what is an enzyme deficient? What is an enzyme deficient? So the enzyme deficient is branched alpha keto acid dehydrogenase. That is branched alpha keto acid dehydrogenase. That's PCKD. Clear? Chale. Next question. What is the first permanent tooth to appear in a child? What is the first permanent tooth to appear in a child? So discuss about a primary dentition, that is milk teeth. Okay, and secondary dentition, that is permanent teeth. Okay, let me write fully. So let's discuss about a primary dentition. Milk teeth, and the secondary dentition, which is permanent teeth. Okay, if you talk about the onset, the primary dentition begins at 6 to 7 months. Okay, the secondary, it begins by 6 years. It begins by 6 years. Okay, if you talk about the first tooth, that is a lower central incisor. That is a lower central incisor. Okay, and if you talk about a permanent one, that is a first molar. That is a first molar. If you talk about the last tooth, that is second molar. And secondary dentition, that is a third molar. It completes at 2 to 3 years, and it completes at 12 years, except third molar. The total number is going to be 20, and the total number, it's going to be 28 to 32. It's going to be 28 to 32. Clear? So which of the following is going to be the first permanent tooth to appear in a child? The answer is going to be first molar. Your answer is going to be the first molar. Okay, clear? Let's move to the next question, guys. A child was brought by his mother complaining of a multiple episodes of loose stools. Also complained of drowsiness, lethargy. Skin pinch was going back very slowly. The child did not accept the breastfeeds. what is the class of dehydration? What is the class of dehydration? So let's discuss about the class of dehydration, whether it is going to be a severe dehydration, it's going to be some dehydration, or it's going to be no dehydration. So if we talk about the following signs, two of the following signs should be there. We can categorize this under the severe dehydration if there is unconscious or the lethargic baby, there are sunken eyes, baby is not able to drink or drinking very poorly, and the skin pinch goes back very slowly. You categorize it under the severe dehydration. Okay. Then if there is restlessness or irritable, drunks eagerly and is thirsty, skin pinch goes back slowly, it's going to be some dehydration. It's going to be some dehydration. And if there are not enough signs to classify as some or severe dehydration, it is a no dehydration, which is green color, so we have severe dehydration, we have some dehydration, and we have no dehydration at all. Okay, now in this given question, guys, child did not accept the breastfeeds, the skin pinch was going slowly, and the child was the lethargic, so it is going to be the severe dehydration. It's going to be the severe dehydration. Now what exactly will be the management for this severe dehydration, bache? So if we talk about the fluids, you need to give, for severe dehydration, you need to give 100 ml per kg. Over 4 hours, we need to give 100 ml per kg over 3 to 6 hours. Let me try. Over 3 hours or 6 hours. So if the age is more than 1, then it's going to be 3 hours. If the age is less than 1 year, it's going to be the 6 hours. Okay, followed by that, so what will be the management for the some dehydration? Give fluid 75 ml per kg, okay, for 4 hours, and give ORS or IV fluid. Give ORS or IV fluid. Okay, we need to give zinc supplementation as well. How much zinc you need to give, guys? If we talk about the zinc supplementation, if we talk about a zinc supplementation, so less than 6 months, we give 10 mg, and more than 6 months, we give 20 mg. Okay, more than 6 months, we give 20 mg. Okay, and if there is no dehydration, then give 5 to 10 ml per kg ORS. (5 to 10 ml per kg ORS). Clear? Now if the diarrhea persists for 14 days or more, if it goes 14 days or more, the severe persistent diarrhea, treat the dehydration before the referral, okay, and refer to the hospital. Okay, if no dehydration, persistent diarrhea, advise the mother to feed a child who has persistent diarrhea. You need to give multivitamins including zinc for 14 days and follow up the patient after 5 days. And if there is a blood in the stool, then it's dysentery. You need to start the antibiotic ciprofloxacin for the 3 days and follow up in 3 days. Is that clear? So that is about the dehydration classification, depending whether it's severe or some or no dehydration. Next, move to the next question. A newborn is brought to the clinic with a swelling over the right parietal region of the scalp, which is noticed shortly after the birth. The swelling is firm, does not cross suture lines. It's gradually increased in size over the first 2 days. There are no signs of discoloration or bruising on the overlying skin. The baby is otherwise active and feeding well. What is the most likely diagnosis? What is the most likely diagnosis? Okay, so let's discuss about the two conditions, caput succedaneum and cephalhematoma. Caput succedaneum and cephalhematoma. The caput succedaneum, guys, it is a soft tissue edema and it extends across the suture line. It extends across the suture line. So you can easily remember caput succedaneum, CS, that means cross the suture. Okay, if it does not cross the suture, that is going to be cephalhematoma or cephalhematoma. What is cephalhematoma, guys? So cephalhematoma, it's a collection of the blood between the periosteum and the skull. It is the collection of the blood between the periosteum and the skull. Okay, caput succedaneum, it's present at birth. Okay, it's poorly defined borders. It may include the ecchymosis and it disappear within 48 hours. It disappear within 48 hours. While as if we talk about cephalohematoma, it's not usually present at birth and it usually is due to the traumatic birth or due to the skull fracture or due to the skull fracture. Okay, and there is increase in the size over the first days of life and it will take months to resolve. It will take months to resolve. Okay, do remember, due to the collection of the blood cephalohematoma, it will be the hemolysis, there will be hyperbilirubinemia. That means jaundice is present in cephalhematoma. Jaundice will be there in cephalhematoma. Okay, so see, hemorrhage is there, due to which hemolysis, blood loss, increase bilirubin is there. And this caput succedaneum, guys, it's just an edema. It's just an edema. Okay, so what is caput succedaneum? So it's a swelling of scalp due to the subcutaneous edema. Swelling of the scalp due to the subcutaneous edema. Okay, so what will be the answer, guys, for this particular question? Tell me in the comment section what will be the answer. It gradually increase in the size the first 2 days. Okay, just after the birth. Okay, there are no signs of discoloration or bruising over the skin. The baby is otherwise active and feeding well. The baby is otherwise active and feeding well. Write down the answer in the comment section. Very good. So it's going to be cephalohematoma. It's going to be cephalohematoma. Chale. A 2-year-old child present to the clinic with a generalized edema, apathy and distended abdomen and depigmented hair. The mother reports that the child diet primarily consists of starchy food with minimal protein intake. What is the most likely diagnosis? What is your most likely diagnosis? So there is a distended abdomen with depigmented hair. You are already studied in the PSM as well. This depigmented hair is called as a flag sign. And there is distended abdomen, protruded abdomen, and it's a classical case of a Kwashiorkor. It's a classical case of a Kwashiorkor. So let's discuss about the Kwashiorkor and marasmus. Okay, let's discuss about the Kwashiorkor and marasmus. Now Kwashiorkor, it develops in the children whose diet are deficient of proteins. It develops in the diet deficient of proteins. Diet deficient of proteins. Okay, and the marasmus, it is deficient of proteins and calories. Deficient of proteins and calories. Okay, next, it's usually seen in the children age group of 6 months to 3 years. 6 months to 3 years of age, and it usually is seen in marasmus, usually is seen in infants under 1 year. Infants under the 1 year of age. Okay, now if we talk about in Kawasaki, subcutaneous fat is preserved. Subcutaneous fat is preserved. Here subcutaneous fat is not preserved. Here subcutaneous fat is not preserved. Okay, Kawasaki edema is present. Here edema is absent. Edema is absent. Okay, there is enlarged fatty liver seen in the Kawasaki. Enlarged fatty liver seen in the Kawasaki, and in marasmus there is no fatty liver. Muscle wasting is mild. Muscle wasting mild. Here we have more muscle wasting. Ribs are not prominent. Ribs are not very prominent. Here ribs are prominent. Here ribs are prominent. Okay, poor appetite. It's voracious feeder. The last one, guys, so baby is lethargic. Your baby is alert or active, and the flag sign, you already know that the flag sign is a depigmented hair, which is seen in the Kawasaki. Okay, next, guys, a 7-month-old baby was brought to the well baby clinic for the routine immunization. He has a weight for height less than 2 standard deviation below the median. What is the most likely diagnosis? So we have discussed weight for height, WHA, weight for height. A is acute malnutrition. A is acute malnutrition. So let's discuss about the formulas: acute, chronic, and undernutrition. If there is decreased weight for age, if there is decreased weight for age, that is going to be acute plus chronic undernutrition. That's going to be acute plus chronic undernutrition, or you can call underweight. Okay, if there is decreased weight for height, if there is decreased weight for height, that is acute malnutrition. That is acute malnutrition, also called as wasting. Okay, and if there is decreased height for age, if there is decreased height for age, that is going to be chronic malnutrition. That is going to be chronic malnutrition, which is also called stunting. also called stunting. Okay, so how to remember, guys? Do remember this with the mnemonic WHA. Weight for height, A is acute nutrition. Okay, do remember height for age with the mnemonic HAC, HAC. Height for age is going to be the chronic undernutrition. Chronic undernutrition. Okay, now we have a criteria for the severe acute malnutrition. Okay, anyone should be present. Severe acute malnutrition, anyone should be there. So what is the criteria? First, weight for height should be -3 standard deviation. Okay, it should be less than -3 standard deviation. Followed by that, sir, mid upper arm circumference should be less than 11.5 centimeter. Okay, and third one, there should be bilateral pitting edema. There should be bilateral pitting edema. Okay, so that is about the severe acute malnutrition. That is about the severe acute malnutrition. Clear to everyone? Yes, clear to everyone? Chale. Okay, so let's take a small break and then we continue with the remaining questions. Then we'll continue with the remaining questions. Chale. Okay, just a short break of 10 minutes. Then we'll continue. Yes, guys, let's begin. I'm audible. Chale. Next question. A 6 month old infant present with a failure to thrive, recurrent respiratory infections, and bulky, foul smelling stools. Okay. A sweat chloride test reveals the chloride level of 75 millimoles per liter. The normal is less than 40. What is the most likely diagnosis? Easy one, guys. What will be the most likely diagnosis? The most likely diagnosis is cystic fibrosis. The most likely diagnosis is cystic fibrosis. Okay, now let's understand what exactly is cystic fibrosis. So cystic fibrosis, it's due to the failure of chloride transport. Sir, it's due to the failure of chloride transport. Okay, so there is a gene mutation. Which gene mutation? So there is CFTR gene mutation at delta 508F. Okay, and due to the gene mutation there are thickened secretions. There are thickened secretions which will lead to the obstruction. Okay, which will lead to the obstruction. Okay, now what are the clinical features, sir? What are the clinical features of a patient having a cystic fibrosis? If we talk about the lungs, from the lungs the clinical feature is going to be bronchiectasis and pneumonia. There will be bronchiectasis and pneumonia. Okay, now if we talk about other features, there will be azoospermia. Which will lead to the infertility. Okay, due to this cystic fibrosis, patient will also have exocrine pancreatic insufficiency, which will lead to this fatty stools. Okay, there is exocrine pancreatic insufficiency. So patient can have sinusitis as well. Okay, now due to this exocrine pancreatic insufficiency, there is a malabsorption. That's why we have fatty stools. Okay, then we have sinusitis as well. Okay, patient can have constipation as well. So these are all the clinical features of a patient having cystic fibrosis. These are all the clinical features of a patient having a cystic fibrosis. Okay, now sir, for the diagnosis, what are the tests that we do? For the diagnosis of cystic fibrosis, what are the tests we do? First of all, we go for the sweat chloride test. Okay, we go for the gene testing, CFTR. We go for the gene testing, bache, which gene? CFTR. Okay, and for the pancreatic insufficiency, we go for stool elastase. For pancreatic insufficiency. Stool elastase for pancreatic insufficiency. Clear? Now if we talk about the treatment, now as there is a thick secretions, thick mucus over there, so what will be the treatment? We need to give a drugs which will break this mucus. So the drugs called as mucolytics. Okay, so for the treatment, sir, we'll give a drugs. Okay, we'll give ivacaftor chloride transporter, ivacaftor, sir, or lumacaftor, or we can give the bromhexine or NAC. What is NAC? Sir, N-acetylcysteine. They will break the mucus. So we give a chloride transporter, ivacaftor, lumacaftor, or we can give a drug bromhexine or N-acetylcysteine or N-acetylcysteine. Is that clear? Is that clear? Yes. Chalo. So sweat chloride test, guys, it is usually a screening test, and if the investigation of choice is asked, your answer should be the gene testing CFTR. Your answer should be CFTR. Okay, in neonates we use one test, okay, trypsinogen, immunoreactive trypsinogen. Okay, that is in the neonates. So in neonates, immunotrypsinogen, number one. Number second, guys, for screening, sweat chloride test, and investigation of choice is gene testing CFTR. That is going to be CFTR. Clear? Chale. So that's about cystic fibrosis. Next one, a syndrome, Turner syndrome. It is monosomy 45XO. Okay, few questions that they can ask from the Turner syndrome. So let's learn about the features of the Turner syndrome first, guys. The Turner syndrome, it will be a short stature with a broad chest or the shield chest with widely spaced nipples. Okay, there will be short fourth metacarpal. Okay, there will be a pubertal failure because of the streak ovaries, because of the streak ovaries. Okay, along with that, the congenital heart defect will be there. And if the question will be most common congenital heart defect associated with Turner syndrome, your answer is going to be, write down in the comment section what will be the answer, guys. Most common congenital heart defect associated with the Turner syndrome, it's going to be bicuspid aortic valve stenosis. It is bicuspid aortic valve stenosis. Okay, now one question was asked, which of the following is incorrect about the Turner syndrome? Remember, guys, in Turner syndrome there is no mental retardation. So there is no mental retardation, first thing. Okay, number second thing, the gene that is defect in the that is there in short stature, the name of the gene is SOX gene. Kaun sa gene hai, guys? SOX gene. Okay, and this Turner syndrome, it is also the most common cause of primary amenorrhea. It is also the most common cause for primary amenorrhea. Is that clear? Is that clear to everyone? So it's all about a Turner syndrome. Okay, chale. Next one is Klinefelter syndrome. Next one is Klinefelter syndrome. Okay, in Klinefelter syndrome, remember, guys, it is 47XXY. First thing. Second, guys, so there is one bar body present, extra X chromatid. Okay, and the features are, in Klinefelter there is a tall stature. Okay, it's mildly impaired. There is a osteoporosis. They will mention in the questions gynecomastia. Okay, long legs, azoospermia or hypogonadism. There are small and firm testes. Okay, these all all the features are of what? Klinefelter syndrome. All features of Klinefelter syndrome. Okay, they will mention in the question azoospermia, and that is due to the testicular atrophy. It is due to testicular atrophy. It's due to the testicular atrophy. So Klinefelter syndrome, the features like gynecomastia, azoospermia, okay, then tall stature mark the Klinefelters. If they ask short stature, okay, webbed neck, widely spaced nipples, go with the Turner's syndrome. Chale. Next question, guys, Patau syndrome, it's trisomy 13. Okay, now the features of the Turner's Patau syndrome are cleft lip or palate. There are clenched hands with outer fingers on the top of the inner fingers. There are closed set eyes. Eyes may actually fuse together into one. There is decreased muscle tone. Okay. There are extra fingers or toes. There are cleft in the iris or hole split. Low set ears. Mental retardation is seen, and that mental retardation can be severe. Mental retardation is seen and that can be severe. They have scalp defects, small eyes, small head, and the small lower jaw. Though please do remember, guys, the cleft lip or palate, it is usually seen in the which syndrome? That is going to be Patau syndrome. कौन सा syndrome है? That is going to be the Patau syndrome. Next is going to be trisomy 18. Next one is trisomy 18. It is Edward syndrome, or it is Edward syndrome. Okay, now Edward syndrome, remember the features of Edward with a mnemonic rock mind. With a mnemonic rock mind. R is rocker bottom foot. Okay, O with overlapping fingers. Then one O with occiput prominent. C is going to be the cardiac defects. K, that's going to be the kidney defects. Horseshoe shaped. M is microcephaly, and I and D is intellectual disability. That is intellectual disability. Edward syndrome, usually rocker bottom feet they will mention, guys. Rocker bottom feet are seen in which syndrome? Edward syndrome. Okay, remember the most common cardiac defect in the Turner syndrome is bicuspid aortic valve stenosis, and in Down syndrome is endocardial cushion defect. Okay, agar Noonan syndrome mein pucha, that's going to be pulmonary stenosis. That is going to be pulmonary stenosis. Okay, now next question. A child who can grasp objects between the thumb and the index finger, waves bye-bye, and stand with but not without support, it's mostly like to have a developmental age of, write down in the comment section, guys, it is mostly likely to have a developmental age of, it's mostly likely to have a developmental age of. Yes, what will be your answer? It's mostly likely to have a developmental age of. It's mostly likely to have a developmental age of. Yes, good. The answer is going to be 9 months. The answer is going to be 9 months. Okay, so let's discuss about the gross motor milestones. Let's discuss about the gross motor milestones. If we talk about sitting with support, that is around 5 months. Okay, sitting without support, 8 months. Crawling, around 8 months. Creeping, 10 months. Creeping stairs, 15 months. Standing with support, 9 months. Standing without support, 12 months. Walks with support, that is 10 to 11 months. Walks without support, that is 13 to 15 months. Climbing stairs, climbing is 2 years, but maturely by 4 years. These are all the gross motor milestones. Okay, now bache, if we talk about fine motor milestones, if we have a bidextrous approach, that is 4 months. Unidextrous approach 6 months. Ulnar grasp 6 to 7 months. Radial grasp 8 to 9 months. Pincer grasp 9 months. Immature, but mature is going to be 12 months. Transfers object 5 to 7 months. Copies line 2 years. Copies circle or dress and undress except the buttons, that is 3 years. Copy square or a rectangle, that is 4 years. Copies triangle or tie shoelaces, that is going to be 5 years. These are the fine motor milestones. Okay, fine motor milestones. Then the further social milestones. The social smile at 2 months. Usually there is no particular trick, but you can make by yourself for one. Chalo, mirror play by 6 months. Stranger anxiety, so 7 months. Waves bye bye, that is what is mentioned in our question, 9 months. Peekaboo 10 months. Points to object 15 months. Domestic mimicry 18 months. Parallel play is 2 years. And nose, name, gender, nighttime continence, that is going to be 3 years. So these are all the social, gross and fine motor milestones. Clear? So the question was mentioned, a child who can grasp objects between the thumb and the index finger, waves and bye-bye, stand with the not without support, it's mostly likely to have a age group of 9 months. Chale. The following finding is a typical feature of. So these notched incisors. Are a feature of which condition, guys? It's going to be congenital syphilis. Okay, now the congenital syphilis, bache, we have a triad. So what is a triad? The triad we have is SNHL, Hutchinson teeth and interstitial keratites. So right. Interstitial keratites. Okay, we have SNHL and we have one more, notched incisors, which is called Hutchinson teeth. It is called as Hutchinson teeth. Clear? We have notched incisors, interstitial keratites, SNHL. Okay, so let's talk about congenital rubella syndrome. Okay, congenital rubella, it is due to the virus called as Toga virus. What is the virus causing it? Called as Toga virus. So the question that they can ask is a triad. What is a triad for a congenital rubella syndrome? We have 3 things again, C, C and D. So we have C, C and D. We have C, C and D. C is going to be the cataract. C is cataract. C, congenital heart defect. So congenital heart defect. And which congenital heart defect is the most common associated with the congenital rubella syndrome? If they ask most common, your answer is going to be patent ductus arteriosus, PDA. And D is deafness, which is SNHL. D is deafness, that is SNHL. C, C and D. Clear? Chale. Now sir, next one is the triad CCD, and next one is the triad which is seen in congenital toxoplasmosis. Congenital toxoplasmosis, you already know that toxoplasmosis is caused by Toxoplasma gondii. Okay, so we have three things in the triad as well. Remember, with H, C and C, where H is hydrocephalus. H is hydrocephalus. C is chorioretinitis. C is chorioretinitis. And C is intracranial calcification. Intracranial calcification. So what are the three things? So hydrocephalus, chorioretinitis and intracranial calcification. That is why the patient who has a congenital toxoplasmosis, they usually complain of seizures. So the clinical features of a patient having a congenital toxoplasmosis are seizures. Okay, now if we talk about the drugs, if we talk about the medication, okay, right, prenatal. Prenatal we give, okay, or in pregnancy also we give a drug, spiramycin. Okay, postnatal, sir, we use three drugs called as, what are the three drugs? Sir, we use pyrimethamine, number first. Number second, we use sulfazidine, and we use leucovorin. Okay, or folinic acid, okay. So congenital rubella, remember Togawa. And there's a classical rash seen in rubella, that is blueberry muffin rash. And this blueberry muffin rash, sir, it is due to the erythropoiesis. Due to the dermal erythropoiesis. Is that clear? So that's all about the congenital rubella syndrome and congenital toxoplasmosis and congenital syphilis. Is that clear? चले आगे बढ़ते हैं. Next question. So a 5-year-old child present with a recurrent fracture following minimal trauma, blue sclera and hearing loss. The radiograph show the generalized osteopenia and bowing of the long bones. What is the most likely diagnosis? Okay, so the most likely diagnosis for this condition is going to be osteogenesis imperfecta. It is osteogenesis imperfecta. Sir, this osteogenesis imperfecta, again the triad. First of all, it is a type 1 collagen disorder. It is type 1 collagen disorder. Okay, now what are the three things we are seeing? Blue sclera, multiple fractures, multiple fractures, and SNHL and SNHL. Is that clear? So that is about the osteogenesis imperfecta. Okay, let's move to the next question. Which of the following reflexes is typically present at birth and disappears by 4 to 6 months of age? Okay, now the newborn reflexes, bache. Sir, first of all, it's a rooting reflex. What is rooting reflex? It started 32 weeks intrauterine life to 1 month postnatal age. Okay, next one, we have a Morrow's reflex, 28 to 37 weeks of intrauterine life to 5 to 6 postnatal age. Okay, then we have a parachute reflex, 7 to 8 months postnatal age, and it persists through life. This can be the question asked, which of the following reflexes persists throughout the life? Your answer is parachute reflex. Your answer is parachute reflex. Okay, then we have a Palmer or the grass reflex, 28 weeks of intrauterine life to 3 months. That is Palmer grass reflex. We have asymmetric tonic neck reflex, 35 weeks of intrauterine life to 5 months postnatal age. Okay, now which of the following reflexes is present at birth and it disappears around 4 to 6 months? Your answer is going to be Morrow's reflex. Your answer is Morrow reflex. Clear? Chale. Next question, guys. A child present with hepatomegaly and hypoglycemia. There is no improvement in blood sugar even after the administration of epinephrine. What is the likely diagnosis? So we have a question from the glycogen storage diseases. Okay, so a patient is presenting to you with the hepatomegaly and the hypoglycemia. Even after the given blood sugar, there was no improvement. And what is the likely diagnosis? So answer is going to be von Gierke's disease. Yes, what's the answer, bache? Von Gierke's disease. So let's understand about the glycogen storage diseases. Chale. First of all, if we talk about type 1 glycogen storage disease, okay, the enzyme deficient is glucose 6 phosphatase. The enzyme deficient is glucose 6 phosphatase. The organs affected are liver and kidney. The key features of a patient having a von Gierke's disease is a severe hypoglycemia, a lactic acidosis, hepatomegaly, hyperuricemia, and hyperlipidemia. So a given scenario was given, a given question, hepatomegaly, okay, hypoglycemia. So the answer is going to be von Gierke's disease. The next question they can ask, what is an enzyme deficient in the given scenario? So you have to diagnose that this is a von Gierke's disease, and the diagnosis is an enzyme deficient is glucose 6 phosphatase. Next one is going to be type 2, which is Pompey's disease. Okay, the Pompey's disease, remember bache, in Pompey's disease the enzyme deficient is acid maltase. The enzyme deficient is acid maltase. Okay, the organs involved is muscle and heart, and the key features are cardiomegaly, hypotonia, and early death. Okay, it causes, so cardiomegaly and hypotonia are associated with Pompey's disease, and the enzyme deficient is acid maltase. Okay, then we have third one, Cory's disease. Okay, the enzyme deficient in Cory's disease is D-branching enzyme. D-branching enzyme. It involves liver and muscles, and patient will complain of a milder hypoglycemia. There is a muscle weakness and hepatomegaly. There is a muscle weakness and hepatomegaly. Next is type 4, which is Anderson disease. In Anderson disease, the enzyme deficient is branching enzyme. The enzyme deficient is branching enzyme. It involves liver and a muscle. Okay, the features are cirrhosis, failure to thrive, and early death. Okay, next one is McArdle's disease. Okay, M for McArdle, M is muscle. It is usually involving the muscle. That's why the patient have exercise intolerance and muscle cramps and myoglobinuria. Okay, the enzyme deficient is muscle glycogen phosphorylase. Muscle glycogen phosphorylase. Okay, now the next one is going to be the type 6 Hers disease. H is Hers. H, you know, hepatic involvement, liver involvement. Okay, so what is an enzyme deficient? It is liver glycogen phosphorylase. Liver glycogen phosphorylase, and the key features are mild hypoglycemia and hepatomegaly. These are the glycogen storage disease. We have type 7 as well. We have type 7 as well, called as Torres disease. Called as Torres disease. The enzyme deficient is phosphofructokinase. Phosphofructokinase. It usually involves muscles and RBCs. Muscles and RBCs. And the key features are hemolytic anemia, and exercise intolerance. And exercise intolerance. Is that clear to everyone? Yes. So glycogen storage disease, guys, important. Biochemistry से भी question पूछ सकते हैं. Remember, if there is a hypoglycemia, hepatomegaly, hyperuricemia, think of a von Gierke's disease, and the enzyme deficient is glucose 6-phosphatase. Pompe's disease, acid maltase. How to remember this branching and debranching? Remember A, B, C, and D. Okay. Anderson is branching and Cory's is debranching, and Cory's is debranching enzyme. Okay, then McArdle's, we have muscle glycogen phosphorylase. M is muscles, so there is exercise intolerance and muscle cramps. H is Hers disease. H is hepatic involvement, so there is hepatomegaly scene. There is hepatomegaly scene. So this is all about the glycogen storage diseases. It's all about the glycogen storage diseases. Let's move to the next question, guys. A 2-year-old child present with a developmental delay, the coarse facial features, hepatomegaly, the corneal clouding. What is the most likely diagnosis? What is the most likely diagnosis? Write down in the comment section. A 2-year child present to you with a developmental delay. Okay, a patient is having a hepatosplenomegaly with a corneal clouding. Okay, corneal clouding. What is the most likely diagnosis? Good. The most likely diagnosis is Hurler's syndrome. Now let's discuss about the lysosomal storage diseases and the enzyme deficient. Okay, now if we talk about the most common lysosomal storage disease, the first one, most common one, is going to be Gaucher's disease. Answer: Gaucher's disease is most common one. The enzyme deficient is glucocerebrosidase. The enzyme deficient in lysosomal storage disease, most common Gaucher's is glucocerebrosidase. Next one, we have Tay-Sachs. We have Tay-Sachs disease. Tay-Sachs disease में enzyme deficient is hexoaminidase A. That is hexoaminidase A. Okay. Next we have Niemann-Pick disease. Niemann-Pick disease. Niemann-Pick disease, we have sphingomyelinase. Followed by that, we have Fabry disease. In Fabry disease, we have alpha galactosidase A. We have alpha galactosidase A. Okay. Next one, we have Krabbe's disease. It is galactocerebrosidase. It is galactocerebrosidase. Followed by that, we have Pompey's disease. That is acid maltase. Or alpha glucosidase. Yes, PDF I'll be sharing, don't worry. PDF I'll share in the MeduHub channel and my channel as well. Okay. Then sir, we have Hurler syndrome or Hunter syndrome. Hurler and Hunter. So whenever we go for the hunt, we need a clear eyesight. Yes or no, guys? Yes, sir. So if it is mentioned that there is no clouding, if it is mentioned that there is no corneal clouding, think of a Hunter syndrome. If it is mentioned that there is a corneal clouding, think of a Hurler syndrome. So hunt करने के लिए you need to see clear. So for hunt, if it's clear, it's going to be the Hunter syndrome. If the corneal clouding is there, it's going to be the Hurler syndrome. Okay. Now if we talk about the enzymes deficient in Hurler syndrome and Hunter syndrome. In Hurler syndrome, it is going to be alpha L iduronidase, and in Hunter it is going to be iduronate 2 sulfatase. Iduronate 2 sulfatase. Last one, guys, we have Sandhoff's disease. We have Sandhoff's disease, and the enzyme deficient in Sandhoff's disease is hexoaminidase A and B. Hexoaminidase A and B. Hexoaminidase A and B. So these are all the lysosomal storage diseases, guys. So remember, Gaucher's, we have glucocerebrosidase. Tay-Sachs, we have hexoaminidase A. Niemann-Pick, we have sphingomyelinase. Fabry disease, we have alpha galactosidase. Krabbe's disease, we have galactocerebrosidase. Okay. Pompey's, we have acid maltase. Hurler, we have alpha 1 iduronidase. Hunter disease, we have iduronate 2 sulfatase. Sandhoff's, we have hexoaminidase A and B. We have hexoaminidase A and B. Clear to everyone? Yes. Now most common is going to be Gaucher's disease. Most common is going to be Gaucher's disease. And the tissue paper like appearance. Okay, crumpled tissue paper like appearance. It is seen with which condition, guys? Which lysosomal storage disease? It is Gaucher's disease. In Gaucher's disease कौन सा appearance मिलता है? We have crumpled tissue paper appearance of cytoplasm clear? And now these are the cherry red spots. Cherry red spots are seen in which lysosomal storage disease, guys? Tay-Sachs. It's going to be Tay-Sachs. So they're also seen in CRAO. They're also seen in CRAO. Clear? So this is crumpled tissue paper appearance of the cytoplasm and cherry red spots seen in Tay-Sachs disease. Clear? चले आगे बढ़ते हैं. Next one is going to be the congenital heart diseases. First of all, we have egg on string appearance seen in transposition of great arteries. Egg on string appearance seen in transposition of great arteries, TGA, and it is usually TGA is also seen with GDM. Remember that, gestational diabetic mother. Okay, followed by that we have figure of 8 appearance. Okay, total anomalous pulmonary venous connection. टैप VC में हमें दिखता है snowman और figure of 8 appearance or figure of 8 appearance. Okay, we have scimitar sign seen with PAP VC, partial anomalous pulmonary venous connection. Okay, then we have VSD, left and right ventricular enlargement, ventricular septal defect. We have coarctation of aorta, COA, figure of 3 or reverse sign. There is an inferior rib notching. Okay, this sign, reverse 3 sign. Then we have a boot shaped heart. Tetralogy of Fallot. It's the most common cyanotic heart disease. It's the most common cyanotic heart disease. Okay, and which shape? Boot shape. We have 4 things: VSD, overriding of aorta, we have right ventricular hypertrophy, and pulmonary infundibulum. Okay, or sorry, pulmonary stenosis, pulmonary infundibular stenosis, all pulmonary stenosis. Okay, and if TOF plus ASD is there, we call it as a pentology of Fallot. क्या बोलेंगे इसको बच्चे? We call it as pentology of Fallot. That is pentology of Fallot. Okay, so they can mention the question that which of the following will describe, or which of the following will describe the cyanosis? The more the pulmonary stenosis, which factor of TOF? The more the pulmonary stenosis, the more the more the pulmonary stenosis, the more the cyanosis. Okay, now next is going to be the patent ductus arteriosus. Okay, PDA. Now one question from PDA will ask which type of murmur is seen. It is continuous murmur or machinery murmur. Continuous murmur or machinery murmur. Okay, now for the PDA, for the closure of PDA, the drug we use is very good. So the drug we use is ibuprofen followed by indomethacin. But for the patency, we use a prostaglandin. Very good. Which prostaglandin, sir? For the patency, we use the prostaglandin, and the prostaglandin we use is alprostadil. The prostaglandin we use is alprostadil. Is that clear? Yes. So let's have a quick recap, because whatever we studied, let's have a quick recap and end it. Chale. So we first started with the jaundice, guys. We first started with the jaundice, physiological jaundice. What is the jaundice? When the bilirubin levels are more than 5 mg per deciliter. Okay. Followed by that, breast milk jaundice. What are the components responsible? Free fatty acids and pregnanediol. Okay, because they interfere with the conjugated bilirubin, which will eventually lead to the jaundice. Okay. Now then we have a types of a jaundice: physiological jaundice and the pathological jaundice. The onset of a physiological is after 24 hours. Please do remember the important things: after 24 hours of life. Okay, and this one is going to be within 24 hours of life. Okay, the peak action on day 3 to 5. Peak action can be at any time. In term babies, it resolves by 1 to 2 weeks, but in preterm, 2 to 3 weeks. But if we talk about the duration in the pathological jaundice, it persisted beyond the normal time. The bilirubin levels, do remember whenever the question comes, bilirubin levels, if less than 15, it is about a physiological jaundice. If more than 15 mg per deciliter, that is going to be the pathological jaundice. Okay, the cause, immature liver enzymes, and here it can be the hemolysis and the infection. Okay, if we talk about the type of hyperbilirubinemia, unconjugated bilirubin in the physiological jaundice, and conjugated or unconjugated in the pathological jaundice. I have mentioned here only conjugated bilirubin is increased in Dubin-Johnson syndrome and Rotor syndrome, other condition as well, but still remember from the syndrome CDR. And Crigl-Najjar 1 and 2 along with the Gilbert, it's going to be unconjugated bilirubin. Okay, then followed by that, risk factor is going to be preterm and delayed feeding. Here the risk factor is hemolysis, usually the RH incompatibility, क्योंकि RH incompatibility में क्या होगा, antigen antibody reaction, hemolysis, kernicterus, and then the hydrops fetalis and other conditions. Okay, complications are rare, but here kernicterus will happen. Management, frequent feeding. Here treat the underlying cause, and phototherapy with a wavelength of 460 around. Chale, neonatal hypoglycemia, sir, it is defined when the blood glucose is less than 40. But if they mention plasma glucose, it's less than 45. But as per the WHO definition, it is less than 45 mg per deciliter blood glucose. Clinical features, the most common is going to be tremors. Okay, followed by that, seizures, poor feeding, increased sweating are the other features of the hypoglycemia. If a patient is symptomatic hypoglycemia, give IV 10% dextrose. If sir asymptomatic, we need to start the breastfeed. Okay, if more than 20 to 40 mg per deciliter. But if asymptomatic and the blood glucose level is less than 20, then start glucose infusion. So remember, in an asymptomatic neonatal hypoglycemia patient, okay, if you have to continue monitor the glucose levels, okay, continue the breastfeed. But if it is more than 20, then breastfeed. If less than 20, then sir, start glucose infusion. Then the recent guidelines in the treatment of the pneumonia, guys, you need to look for the danger signs, and followed by that, look for the respiratory rate as per the age, and check for the chest retractions or the chest indrawing. Then following are the 3 categories. If there are any general danger signs or stridor in the child, you categorize it as a severe pneumonia, and you have to give ampicillin and gentamicin as an antibiotic. Refer the patient on oxygen to the higher center. If there is a fast breathing or chest indrawing mentioned in the question, it's a case of a pneumonia. Okay, give amoxicillin for the 5 days and follow up in the OPD. And if there are no signs of pneumonia or no very severe disease is there, no danger sign is there, there should be no antibiotics and only the supportive care. Then we further discussed about the feed of preterm gestational age, less than 28 weeks, we give IV fluids and total parenteral nutrition. 28 to 31, we give orogastric or tube feeding. Okay, 32 to 34, paladai feeding or katori spoon feeding, and more than 34, you have to go for breastfeeding. Further, we discuss about a case having a seizure with multiple ring enhancing lesions, Neurocysticercosis, guys. You already know that it is due to the Tina solium, okay, pork. Okay, and the drug of choice is going to be albendazole. This parasitic infection, the drug of choice is albendazole plus the steroids. What will steroids use? So we use steroids like prednisolone and dexamethasone. Eventually they will decrease, sir, the inflammation. A girl is born. Then we discuss about the Down syndrome. Okay, then we discussed about the Down syndrome, trisomy 21. a patient of a Down syndrome are more prone to the duodenal atresia, Hirschsprung disease, or the Alzheimer's have discussed. Please do remember the triple test. In the triple test, what will be the components that will be increased? There in quadruple test, only thing will be increased is beta ECG. Rest everything is going to be decreased. Okay. Remember the most common congenital heart defect is endocardial cushion defect. It's endocardial cushion defect. Okay. Then further, a 6-year-old boy, we discuss about the vasculitis, which is most common in the pediatric age group. That is going to be HSP. Okay, HSP of 3 words. So the type 3 hypersensitivity reaction. Okay, any palpable purpura. Okay, with any one of these clinical features. What are the clinical features? So arthritis, arthralgia, so abdominal pain, hematuria, or biopsy shows IgA deposition. That is a case of HSP. Remember, the platelet count is normal. Okay, and the purpura here, it is due to the vasculitis. It's due to the vasculitis. Okay, what is the for the diagnosis? For the diagnosis, so we go for skin biopsy. Please do check the image of the skin biopsy, IgA deposition and dermal papillae. Okay, chale. Then next one we discuss is Kawasaki's disease. Okay, it's also called as mucocutaneous lymph node syndrome. Age usually is less than 4. A patient will come with the following features. There can be a bilateral non-purulent conjunctivitis with macropapillar rash, cervical lymphadenopathy, strawberry tongue, and edema, along with a fever more than 5 days. Classical case of Kawasaki disease. Due to the involvement of coronary arteries, patient can have a myocardial infarction. Treatment is IV immunoglobulin and aspirin. Remember, this is the only condition जहाँ पे aspirin देते हैं बच्चों में, otherwise they will cause a Ray's syndrome. If IVIG is not supporting, we go for the steroids as well. If the question asks most common complication in Kawasaki disease, your answer is going to be the coronary artery aneurysm. Your answer is going to be coronary artery aneurysm. Okay, followed by that, these are the rash picture. This is going to be conjunctivitis, strawberry tongue, hand swelling, feet swelling, cervical adenopathy, coronary artery aneurysm, and peripheral artery aneurysm. Then the CHPS, which of the following is not a feature? Bilious vomiting is not a feature, guys. Bilious is seen in duodenal atresia. Okay, what is CHPS? So there is a hypertrophy of the pylorus, which will lead to the gastric outlet obstruction. It's usually seen in male baby around the 6 to 8 weeks of life. The features are vomiting, which is projectile and non-bilious. There is a palpable lump, which is felt, olive mass. Due to the continuous vomiting, baby will have dehydration and the weight loss, and there is visible gastric peristalsis. Okay, electrolyte imbalance has been the question asked. Metabolic alkalosis, hypokalemia, and hypochloremia. Risk factor for this is maternal intake of a drug called erythromycin, which is a macrolide. Diagnosis, USG abdomen. We have a donut sign there. Remember, for the treatment, surgical treatment is Ramstead's operation and correct the electrolyte imbalance, normal saline with added potassium. Okay, Apgar score, it's a prognostic score done at 1 minute and 5 minutes. If less than 3, baby needs a resuscitation. Okay, so the data was given and the Apgar score calculated was 6. Chalo, remember in Apgar score it is respiratory effort, not the respiratory rate. We have Shakir stay bache, mid upper arm circumference. We have free zone, red, yellow and green. Less than 11.5 is red, 11.5 is yellow, more than 12.5 is green zone. Clear? And this Harpender's calipers, which measure the skin fold thickness, usually at 4 sides. We have biceps, triceps, subscapular area. Okay? Chale. Next one, we discussed about the phenylketonuria. It is due to the deficiency of phenylalanine hydroxylase, because when phenylalanine is not converting to the tyrosine, phenylalanine will be increased, which is toxic to the CNS. That's why the patient is having the neurological manifestations. When the tyrosine is decreased, there is decreased melanin, because melanin is coming from tyrosine. We have a hypopigmentation. So hypopigmentation with neurological manifestation, these features are more of a phenylketonuria. Melanin agar absentee hoga, to the condition is called as albinism. The enzyme deficient was asked, it is going to be tyrosinase. Okay, albinism, what is an enzyme deficient? So an albinism enzyme deficient is tyrosinase. Enzyme deficient is tyrosinase. Okay, followed by that, first molar tooth, say tooth in the permanent or secondary dentition is going to be first molar. Okay, Then we discuss about the dehydration, severe, some and no dehydration depending upon the symptoms. Look for out for these symptoms, okay, whether the baby is thirsty or baby is not able to drink, okay. 100 ml per kg over 3 hours to 6 hours depending upon the age, more than 1 year 3 hours, or less than 1 year 6 hours. And if there is a some dehydration, 75 ml per kg for 4 hours, ORS and IV fluids. Never give IV fluids alone, direct RL nahi dena, mix it with the dextrose. And if there is a no dehydration, 5 to 10 ml per kg ORS. Okay, osmolarity of ORS, if they ask, it is 245 millimole. Please do remember this. Chale. Next one is the succedaneum and cephalohematoma. Succedaneum, C is gross, S is suture. So if gross the sutures, that is going to be the caput. Succedaneum, it's just a swelling, soft tissue edema. There are poorly defined borders, it disappears within 48 hours. But cephalohematoma में jaundice भी present हो सकता है due to the accumulation of the blood, hemolysis is there, okay, and it's usually present at the birth due to the traumatic birth or the skull fracture. It takes months to resolve. Next question, we discuss about Kwashiorkor and marasmus. Remember guys, there is deficient of proteins, it's deficient of proteins as well as the calories, okay. There is a depigmented hair flag sign which is seen in the Kwashiorkor, protruded abdomen, here prominent ribs are seen, mild muscle wasting, more muscle wasting, okay. In marasmus, it's a old man faces, there are old man faces, okay. Usually the age group is 3 months, 6 months to 3 years, and it's under 1 year. Clear? Then we discuss about the criteria for severe acute malnutrition. Weight for height should be -3, less than -3 standard deviation. Mid arm upper circumference should be less than 11.5 centimeter, and there should be bilateral pitting edema. Okay. Then we discuss decreased weight for age. We have acute plus chronic undernutrition. Weight for height, we have acute malnutrition, and height for age, we have chronic malnutrition. We discuss about the cystic fibrosis. It's a chloride channel defect, okay, due to which there are thickened secretions which will cause the obstruction and lead to the bronchiectasis, pneumonia, infertility. There is an exocrine pancreatic insufficiency, fatty stools, sinusitis, and constipation. Okay, for the diagnosis, sweat chloride test, we go for gene testing. These are all the screening tests, but the investigation of choice is CFTR. We also go for the in newborns. We also go for the trypsinogen, immunoreactive trypsinogen levels, and stool elastase for pancreatic insufficiency. Whenever there is an exocrine insufficiency, give pancreatic enzyme. Agar endocrine insufficient होती है, then give insulin. ठीक है ना? Treatment guys, chloride channel transporter, we have ivacaftor and lumacaftor, and in order to break the mucus, we give the mucolytic drugs like bromhexine and N-acetylcysteine. Then we discuss about the Turner syndrome, 45XO. There is no mental retardation. The most common congenital heart defect is bicuspid aortic valve stenosis. Remember, it's the most common cause of primary amenorrhea, short chest, short stature, webbed neck with streak ovaries, okay, and knee deformity. These are all the features of Turner syndrome. Then we discuss about Klinefelter syndrome, tall stature, gynecomastia, azoospermia, okay, hypogonadism, and 1 bar body, 47XXY. Then Patau syndrome, having the features of cleft lip or cleft palate. Mental retardation is severe over there with small eyes, head, and lower jaw. We discuss about trisomy 18 Edwards syndrome, or the, okay, what are the clinical features? Rocker bottom foot, overlapping fingers, occiput prominent. There are cardiac defect, horseshoe shaped kidney, and intellectual disability. Further, we discuss about the gross motor milestones, fine motor milestone, and social milestone. Do remember them guys. Followed by that, we discuss about the triad of a congenital syphilis. We have interstitial keratitis, SNHL, and Hutchinson's teeth. These are the notch incidents, Hutchinson's teeth seen in congenital syphilis. Congenital rubella guys, Togga virus. The triad is cataract. Congenital heart defect, the most common is going to be PDA, deafness is SNHL. And due to the dermal erythropoiesis, we have a classical rash seen in rubella, blueberry muffin rash. We have congenital toxoplasmosis, Toxoplasma gondii. Three features: hydrocephalus, chorioretinitis, and intracranial calcification. Due to this hydrocephalus, the patient can have a seizures as well. Prenatal sir drug क्या देंगे? Spiramycin. Postnatal sir pyrimethamine, sulfazidine, and leucovorin. Further, a 5-year-old child present with the recurrent fractures, blue sclera, and hearing loss is a classical triad for a osteogenesis imperfecta. It's a classical triad of osteogenesis imperfecta. Chale, next question, guys. The reflex which was present at birth and disappear around 4 to 6 months, that's going to be Morrow's reflex. And the reflex which persists through life, it's a parachute reflex. It persists through life. It's a parachute reflex. Okay. Then we discussed about glycogen storage disease. Okay, a patient is coming to you with the hepatomegaly and hypoglycemia, and there was no improvement in the hypoglycemia even after the blood sugar administration and epinephrine. The diagnosis is von Gierke's disease. The enzyme deficient is glucose 6-phosphatase. Okay, the features of hypoglycemia, hepatomegaly, and hyperuricemia are there. If Pompey's, it's acid maltase. Corey's, D branching. Anderson branching. I told Anderson, remember ABCD. Anderson for branching, Corey's for D branching. McArdley's involving muscles, M with muscle glycogen phosphorylase. Hers is hepatic liver glycogen phosphorylase. So exercise intolerance and mild hypoglycemia are the features of the McArdley and Hers disease. We have type 7 Torrey's disease, bache, phosphofructokinase. Patient can have exercise intolerance and hemolytic anemia. A 2-year-old child present with a development delay, we talked about the corneal clouding is there. It's Hurler syndrome. If no corneal clouding, it's going to be Hunter's syndrome. Remember the enzyme deficient, Gaucher's में glucose cerebrosidase. Tay-Sachs, it's hexoaminidase A. Niemann-Pick, it's sphingomyelin. Fabry, it's alpha galactosidase. Krabbe's, it's galactocerebrosidase. Pompey's, it's acid maltase. Hurler, alpha L-iduronidase. Hunter's, iduronate sulfatase. Sandhoff's, hexoaminidase A and B. Most common is going to be Gaucher's disease with a crumpled tissue paper appearance of the cytoplasm. Exactly, that is Gaucher's disease. Next one is a cherry red spots that are seen in Tay-Sachs or CRAO. Followed by that, egg on string, it's going to be the transposition of gate arteries. Figure of 8, it's TAP-VC. Scimitar sign, it's going to be PAP-VC. Reverse free sign, coarctation of aorta. Okay, the patent ductus arteriosus, remember there is a left side enlargement. Continuous murmur or machinery murmur seen. For the closure, we use ibuprofen, then indomethacin. For patency, prostaglandins, L-prostadil. Tetralogy of Fallot, which is the most common cyanotic heart disease, having a 4 features: VSD, overriding of aorta, right ventricular hypertrophy, and the pulmonary stenosis. Jitna zyada pulmonary stenosis hoga, the more a patient will have cyanosis. And if ASD is added into the tetralogy of Fallot, it becomes the pentology of Fallot. And next one, this one, it's a box-shaped heart. This box-shaped heart is Epstein anomaly. Sir, it's Epstein anomaly. And this Epstein anomaly, it is due to which drug? It is due to which drug? It is due to the lithium intake. It is due to the lithium intake. So that is all about the pediatrics. Is everything clear, guys? Yes, we had a delay in this pediatric session, but yes, we are done with it. Please do revise it, but moreover, go with the PSM and obs and gynae. We have done a detailed revision of obs and gynae and PSM. And for the pediatrics, guys, I think this much is okay. I'll see whether we go for the part 2 or not. We had a 3-hour session, so do go through these topics, and other than these topics, go for the seizures. Check all the seizures in neonates, children's, pediatric age group. Okay, go for the staging for NEC. Okay, check other topics as well. Clear? बाकी सारे टॉपिक्स भी देख लो. Go for the recall as well. And in case any doubt, do let me know. I hope the session was interactive enough. Okay, so just few days away. Okay, next Monday. Right now everything is done and dusted, so be confident. Okay, so few things I would mention before I end this session. Please be confident. Whatever you have studied, trust yourself, trust your notes, trust the faculties, trust the teachers you have studied from. Okay, right now you might feel anxiety, you might feel that you don't know anything, you might feel you're not able to recall, but trust me, everything will make sense once you will see a question with 4 options. Yes, there will be bouncers, there will be hard questions as well, but we just need 150. Okay, so don't let the good questions, okay, to take away your, don't let the bad questions to take away your the good questions. Yes, there will be up and down, but eventually be focused. Okay, remember, we never lose, we either win or we learn. I repeat it every time. So give your best shot on the 26th of July. Okay, whatever will be the result, we'll see it later, but make sure every answer you mark, read question twice. Okay, avoid the silly mistakes. So thank you for the interaction, guys. If you have any doubts related to the PSM, obstetrics or pediatrics or anything I can help with, you guys can contact me, and make sure your text should be only related to the doubts and studies. Okay, so take care, all the best, and I'm waiting for you all to welcome this side. Okay, and you soon are going to be the doctors. Take care, goodbye, Allah Hafiz.